আচ্ছা, হ্যালো।
हेलो
হ্যালো।
हेलो डॉक्टर घोष
হ্যাঁ, হ্যালো
गुड
হ্যালো।
इवनिंग सर गुड इवनिंग सर স্যার আপনার মাইকটা আনমিউট করুন দিয়ে বলুন ডক্টর সৌম্যজিৎ ঘোষ প্লিজ আনমিউট ইউর মাইক Dr. Somojit Ghosh, am I audible to you?
তোমার নাম্বারটা সাধারণ নিজেদের নাম্বার চর্মরোগের তো আছে
লোকজন সবাই জয়েন করতে পারেনি আগে করে জয়েন
বারবার আমাকে শেয়ার করে না সবাই এখানেই আসবে ঘটনা বলতে যাবে
Am I audible?
Yes, sir. Yes, sir. You are absolutely audible, sir.
Am I audible?
Yes, sir. You are absolutely audible, sir. Mr. Ghosh, Dr. Ghosh. Dr. Ghosh. Dr. Ghosh, Dr. Somojit Ghosh. Are you hear me, sir?
His mic is on.
Swati, madam, his mic is on.
Yeah, his mic is on. Log out हो गया अभी sir.
I think there is a technical issue that is facing. Madam, can you call him? Swati ma'am.
हाँ दादा बोलिए ना.
Can you call him?
नंबर दे दीजिए उनका.
नंबर मैं बोलता हूँ.
व्हाट्सएप कर दो ना नंबर.
ओके, आपको तो व्हाट्सएप किया ही हुआ है.
नहीं है.
अरे वो इसमें तो है ना. गैलेक्सी का मॉडरेटर है उसमें।
हाँ, yes, yes.
Am I audible?
Yes, sir, you are audible.
Sir, yes, yes.
Am I audible?
Yes, you are audible, sir, and you are visible also. Can you hear us, sir? Dr. Ghosh, can you hear us?
अरूप जी, ये जो ब्लूटूथ डिवाइस कनेक्ट किया है ना, तो उनसे चेक करना पड़ेगा उन्होंने पेयरिंग किया है कि नहीं किया है। पेयरिंग किया होगा तो उनको सुना ही आएगा।
ओके, मैं डॉक्टर साहब को बोलता हूँ कि वो हेडफोन से
हाँ, नहीं, ये ब्लूटूथ से कोई प्रॉब्लम नहीं है, बट उनको पेयरिंग करना पड़ेगा। बस ये जो है मैटर करता है। जैसे हम ब्लूटूथ स्पीकर भी रहता है तो हम पेयरिंग करते हैं ना, बस वही कॉन्सेप्ट एप्लीकेबल है।
ओके ओके, मैं कॉल करता हूँ।
Am I audible?
Yes, sir, you are audible.
अरूप जी, हेलो अरूप जी।
यस,
ये थोड़ा डॉक्टर अश्विनी के यहाँ से कुछ है ना, बहुत वो आ रहा है, वॉइस आ रहा है, और शायद उनको आवाज नहीं जा रहा है हमारा।
ओके, मैं बोलता हूँ।
हाँ, क्योंकि शायद उन्होंने कनेक्ट किया हुआ है, लेकिन उन्हें वो ब्लूटूथ डिवाइस है।
हाँ बोले।
हाँ राणा सर।
हेलो,
हाँ,
am I audible?
yes sir, yes sir,
Am I audible? Okay.
yes sir, very much you are
Okay.
audible. हाँ, एक्चुअली सर
Okay.
आपके वहाँ से बहुत नॉइज आ रहा है सर, तो थोड़ा उसको अनम्यूट कर दीजिए ना सर प्लीज।
ठीक।
थैंक यू सर, थैंक यू वेरी मच। डॉक्टर घोष, प्लीज अनम्यूट योर माइक। First, unmute your mic.
Am I audible?
Yes, sir. You are audible. Can you hear us, sir?
Okay, sir.
Can you hear us, sir?
Yes, I am hearing. Can you hear me?
हाँ, sir. Your voice is very low, sir.
Audible?
You are audible, sir, but your voice is low, sir.
Still low. Now?
Now is same, sir.
Is there an increment?
No, sir.
Arupji, let us know when to start.
Yeah.
It's 8:15. That's why.
Yeah. Please connect the audio links also, sir.
Okay.
I can hear you.
Arup, now we can start, Arup.
Yes. Yeah, boss.
Yeah, we are live on audience link also. Over to you.
Good evening, sir.
Hello,
Good
everybody.
evening, all, sir.
Hello.
On behalf of Alchem Laboratories, sir, the Alchem is the five largest company in India. I am Arup Agarwal, sir, and I am covering Bardhaman region, that is RM Bardhaman, and welcome our eminent doctor who have joined today's panel discussion, Galaxy, on rosuvastatin, sir. At Alchem, it was endeavor with healthcare professional, and we will continue to do so in these challenging situations also. To help us navigate through the meeting, we have with us today's moderator, Dr. Soumyajit Ghosh, the eminent cardiologist from Bardhaman. Dr. Ghosh, you are welcome, sir. Dr. Ghosh.
Am I audible?
Yes, sir. You are welcome, sir.
Okay, thank you. Good evening.
And nothing to elaborate, sir. And I hand over the session to you, sir.
Particularly rosuvastatin.
Your voice is very low, sir. Please.
Is it audible now?
Audible, sir, but it is low, sir.
It is 100% now.
Okay, sir.
Very much pleasure to have panelists like Dr. R.N. Maiti, Senior Consultant Physician from Midnapur, Dr. Oshini Rana, Consultant Physician from SSKM Hospital, as well as he's practicing in Midnapur. Dr. Vikram Mohapaତ୍ର is eminent cardiologist from Siliguri and practicing at Paramount Nursing Home, as well as Dr. Judhishthir Das.
Your voice is not audible actually.
This is not audible, no?
Yes.
Sir, you can remove your headphones, sir. I think it will be work better.
Is it audible now?
Yes.
Very clear, sir.
Absolutely.
Am I audible?
Yes, sir. You are audible.
Yes. Okay. So we start with discussion with Dr. Maiti. So Dr. Maiti, we are using statin, particularly rosuvastatin, for long times, for about 2 decades, particularly for ASCVD patients who is having ASCVD as well as patients who are having high risk for ASCVD. So can you tell me what is your experience on statin, particularly on rosuvastatin, and how you are using statin in patients of ASCVD? Dr. Maiti, please.
Some network issue is there, sir, I think.
I can't hear Dr. Maithi's voice.
Hello. Hello, Ambrish. Ambrish. Hello, Ambrish. Swati ma'am.
Yeah, I'm calling up him. Yes.
Ambrish hai. Is there any network issue?
Hey, Dr. Ramayan Maiti, he's not on mute.
हाँ.
Ambrish, हाँ ये ना
Dr. Ghosh, I think Dr. Maiti facing some challenges regarding network issue.
Dr. Maiti, can you just remove your headset? Sir, you have to remove the headset.
Dr. Ghosh.
And Dr. Maiti also. Sir, can you hear us now? Dr. Maiti?
Yeah. Audible.
Sir, can you hear us?
I can hear you.
Yes,
but I
yes,
can't
yes.
hear,
Yeah, now we
can you
can
hear
continue, sir. Yes, Dr. Ghosh, we can continue.
Yes, I can't hear from Dr. Maiti.
Yeah, he can hear us.
So, in my experience, your question was my experience with rosuvastatin. I have
Yes,
used a lot of rosuvastatin so far, starting from 10 milligram to 40 milligram, and in patients with stroke, migraine infarctions, and patients with diabetes mellitus and hypertension, in all sorts of patients. And in my experience, rosuvastatin is not inferior to atorvastatin, which is widely used so far, and it is beneficial, particularly in younger age group of patients, because we should take into consideration the age of the patient, because it is more beneficial. There is evidence that it is more beneficial in younger age group of patients than the elderly age group of patients, because there are polypharmacy in elderly age group of patients, and there are some risk of side effects in the elderly age group of patients. So we are little much skeptic about their use in elderly age group of patients, but still I use routinely in patients of hypertension and diabetes mellitus this rosuvastatin. Okay.
Okay, sir. But it's nicely explained your experience. Now, Dr. Rana, what is your experience about reduction of ASCVD risk with statin, particularly rosuvastatin? What is your personal experience? Is there any decrement of risk, particularly for primary prevention or for secondary prevention of patients with ASCVD?
Definitely, there is risk reduction in primary and secondary prevention. I prefer aggressively lowering of the LDL cholesterol. In case of primary prevention of any kind of dyslipidemia, maybe diabetic dyslipidemia, and also I have shown many times in secondary prevention of cardiovascular disease. There is also lots of study. There is also lots of study which shows mortality benefit, which mainly we have lots of study like 12% of decrease of mortality in statin treatment compared to the other study, and also we have shown many study which shows major cardiovascular event reduction, which range from 13% to 41%. And in these all studies, we have actually shown that rosuvastatin is more efficient than atorvastatin. So I personally prefer rosuvastatin apart from atorvastatin in reduction of risk in case of primary and secondary prevention.
So, yes, Dr. Rana, your experience is more favor of rosuvastatin. So, Dr. Das,
Rosuvastatin, yes.
Dr. Yudhishthir Das, can you tell me, is it actually what is the problem of rosuvastatin or atorvastatin? You are using more rosuvastatin compared to atorvastatin. Both are statin, both are from the same group of drugs. Is there any any difference? And have you seen any difference between atorvastatin and rosuvastatin, particularly for a patient of established cardiovascular disease? What is your experience and what is the result of different trials? Can you share your experience on the results of trials? Is there any particularly any difference between atorvastatin and rosuvastatin, efficacy-wise? Dr. Rana, can you hear me? Dr. Rana, can you hear me?
Dr. Rana,
Yes. Please,
So,
please
so
repeat. Please repeat the question.
what is the question that you are telling that rosuvastatin is preferable over atorvastatin?
Yes.
Is
In
there any
my
particular trial or
partial.
is there any evidence that rosuvastatin is more in favor? You are favoring rosuvastatin more in patients of ASCVD, particularly for primary or for secondary prevention than atorvastatin. Is there any some trials or there any real world experience or it is your personal experience?
It is mainly, I think, it is my personal experience,
Your
and also
personal
there are lots of trials, but I could not remember the particular trial right now. There are lots of trials, but in my personal experience, it is I prefer rosuvastatin.
Efficacy wise, molecular level per milligram, atorvastatin, rosuvastatin is superior to atorvastatin, but
Superior
for
to atorvastatin.
yes, but for particular reasons, suppose you are using 5 milligram rosuvastatin, it is equivalent to 10 milligram of atorvastatin. Okay. So, Dr. Mohapatro, Dr. Vikram, can you share me your experience, particularly for patients?
Background noise, your voice actually
Yes,
not.
there is background voice.
Yes.
Yes. Dr. Mohapatro, can you tell me what is your experience, particularly for patients who are undergoing PCI, you are using for secondary prevention for high intensity statin? And what is
Both atorvastatin and rosuvastatins are used, but in some cases I prefer rosuvastatin where myopathy is more in atorvastatin than rosuvastatin. I think in my experience I got atorvastatin with less myopathy incidence.
you are telling that there is a risk of myopathy more in case of rosuvastatin?
No. Atorvastatin.
In atorvastatin, yes. And what is your experience of developing diabetes, or particularly for development of glucose intolerance, particularly for IFG?
In young adults, the risk of diabetes is there, and you have to give lipidemic agent like atorvastatin or rosuvastatin with diabetic groups. You have to give, otherwise the dyslipidemia will be very much in diabetic group. But in young there is risk. Definitely there is risk.
In young patients, particularly for IGT or IFG, who are pre-diabetic patient, if we are using statin, there is chance of diabetic control will be get worse.
In future, yes. They are getting diabetic in future actually.
So in patients who are undergoing primary PCI or for delayed PCI or for primary intervention, you are using statin in a high dose. So what is the time of how you are using and what is the dose you are using, particularly for rosuvastatin?
Or at least 3 months we are giving high intensity study. Then we don't go to low intensity studying, but moderate intensity study like from 40 milligram to 20 milligram
For
rosuvastatin
1 year.
Yes, yes. In atorvastatin case, we are giving 80 milligram to 40 milligram.
So we are seeing that atorvastatin and rosuvastatin both are using in from moderate to high intensity along with low intensity in different spectrum of diseases or atherosclerotic heart disease. In case of primary PCI, in case of acute myocardial infarction of acute ACS patients, as well as for stable CAD, in spectrum of disease, as well as patients of peripheral artery disease, as well as for cerebrovascular disease, we are using. Dr. Das, can you hear me?
Yeah.
Yes. So, is there any particular evidence you are using the drug for a case of cardiovascular, for cerebrovascular disease, for prevention of cerebrovascular disease, or for patients who are having atherosclerotic cerebrovascular disease like infarct or ischemia?
There is some trial, but it's the CARDS trial, showing that there even the low dose of the statin or low dose of the statin, particularly the atorvastatin or rosuvastatin, if the percent of the stroke, about 13 to 20% reduction of the stroke, and even the low level of the LDL cholesterol, while the CRP is the mode, showing that definite reductions of the stroke, particularly the cerebrovascular accident or the TI, transient ischemic attack. When we choose the lipid lowering agents, particularly we choose the statin, among the statin, atorvastatin or rosuvastatin. Potentiality, the atorvastatin is the better than the atorvastatin, but we also can use the atorvastatin. Because the statin have also some pleiotropic effect. Besides the reductions of the LDL cholesterol or other the cholesterol, it has the anti-inflammatory effect and also the improve the actions of the endothelial cells and etc. So there is the definite reductions of the stroke along with some of the study, particularly the CARD study. The CARD study shows the definite reductions of the stroke.
Okay. And what is your experience for patients with type 2 diabetes? Whether a patient of young type 2 diabetes without having dyslipidemia, without any atherosclerotic cardiovascular disease, are you using statin? Or is it justifiable for using statin in patients of type 2 diabetes who are not having atherosclerotic cardiovascular disease as present, or clinically at least no atherosclerotic disease? Is it justifiable to use statin? And what will be the dose?
Yes, this is the justifiable. I already said that the statin have the pleiotropic effect, and some the study, particularly all the guidelines from the America, not the European guidelines. There is a definite reductions of the mortality and other things, particularly the age, the more than the 40 years with diabetes. Though there is some the increase the incidence of the impaired the fasting glucose or the incidence of the newer onset of the diabetes, but it is the overweight the benefit because there is the reductions of the mortality and other things, particularly the cardiovascular event due to the pleiotropic effect. But even in the European guidelines showing that the diabetes, all the patients with diabetes without the atherosclerosis, this is only the risk factor we can definitely use statin. Most of the American guideline, so only the diabetic patient more than the 40 years we can use the statin, and I will follow this rule for a long time and will give the definite benefit in our clinical practice.
Yes, sir. Actually, for type 2 diabetes patient, if he is above 40 and up to 75, you have to use statin. And according patient's risk of development of atherosclerotic cardiovascular disease, if the risk is below 7.5, you have to use low to moderate intensity, and above 7.5, you have to use high intensity statin, particularly for diabetic patients. And diabetic patients are often considered as coronary artery equivalent. So we are using statin. Dr. Maiti, can you tell me that what is your experience of using statin and what is the chance of plaque regression, particularly patients of atherosclerotic cardiovascular disease for secondary prevention? We are using statin. Is there any chance of plaque regression or the change of plaque morphology or plaque stoichiometry? Any change after using statin? Dr. Arun,
Definitely, after rosuvastatin scores over can you hear me?
Yes, we are hearing.
Am I audible?
Yes, you are audible.
Definitely, the evidence different evidences supports that rosuvastatin scores over atorvastatin in causing regression of plaque and reducing all-cause mortality and all sorts of myths. And particularly the patients with this hypertension and obesity. So in that case, we use rosuvastatin for primary prevention and also as secondary prevention, particularly younger age group of patients between 40 to 75 years of age. But there is little doubt whether those are very much beneficial in elderly age group of patients more than 75 years of age and with other comorbidities. So I prefer rosuvastatin, particularly in the patients of diabetes mellitus and hypertension for causing for primary prevention.
Okay, sir. Thank you. Dr. Mohapatra,
Yes, yes.
we are using different statin combination. Statin with particularly antiplatelet drugs like atorvastatin with aspirin, rosuvastatin with clopidogrel, atorvastatin with dual antiplatelet drug. So whether this is pharmacokinetically or pharmacodynamically, these combinations are preferable, or where you are using monopill and different combination or fixed dose combination, what is preferable?
Actually, for the first year after PCI, we are using high intensity statin and moderate intensity statin, where we are using monopill. But after that, we are using the combination pill with clopidogrel and aspirin. For first year, we are using monopill as atorvastatin or rosuvastatin with aspirin and ticagrelor. After that, we are switching over to the combination pill.
Combination therapy. After 1 year of intensive therapy with atorvastatin with dual antiplatelet, you are switching to monotherapy of antiplatelet as long as atorvastatin. And the dose of atorvastatin is also you decrement from high intensity to moderate or low intensity.
Low intensity. Yes.
Am I? Yes, it is the strategy. Dr. Das.
Yeah.
So in type 2 diabetes patients, particularly for young adults who have developed diabetes or who are on verge of developing diabetes, that is patient of IFG or IGT, if we use statin, atorvastatin or rosuvastatin, this chance of increments of blood sugar is there. But is there any difference between atorvastatin and rosuvastatin, particularly for development of diabetes or for decrement of control or for uncontrollability? Is rosuvastatin score over atorvastatin or atorvastatin scores over rosuvastatin? What is your experience and what is the data of different trials?
In my experience, the model is the same, but rosuvastatin to some extent they have the better result. Okay. But in our experience, the model is the same. But the slight increase of the diabetes, but you onset the diabetes, the beneficial is the more with the statin. So we can use the statin. Don't afraid for newer diabetes. Already the diabetes, the Indian is the diabetes epidemics. The further studies are needed whether the actually the new onset the diabetes is the harmful due to the effect of the statin or not. So the atorvastatins and the head-to-head the trial is not still not known to me which one is the better. But to some extent, the rosuvastatin is the more is the impaired fasting glucose than the atorvastatin.
So you are saying that for diabetes control, rosuvastatin is better than compared to atorvastatin. Dr. Rana. Dr. Rana, can you hear me?
Dr. Ghosh, I think Rana has been locked it out.
Oh, Dr. I am not seeing you. Yes. So, Dr. Mohapatra, We are using both atorvastatin and rosuvastatin for secondary prevention of atherosclerotic cardiovascular disease. Is there any what is the relation, particular relation, or there any correlation between level of blood cholesterol, particularly LDL, and decrement of risk for development or for increment or for progression of atherosclerotic cardiovascular disease, or this is just a pleiotropic effect of statin?
Yes. This is not only pleiotropic, but definitely there is therapeutic benefit both in rosuvastatin and atorvastatin, particularly more in rosuvastatin, I think.
So we can say that the effect of statin is beyond lipid control.
Yes.
Effect of statin, particularly for development or for decrement of atherosclerotic cardiovascular disease, the risk of
Definitely. Low, the risk is low with statin use.
Yes. So can we conclude that is there any conclusion that statin is not a lipidological drug, it is a cardiovascular drug?
Yes.
In case for dyslipidemic patients with high LDL or patients with low HDL cholesterol, we are using statin for long time. But particularly in patients of atherosclerotic cardiovascular disease, I think is there any justification for testing for cholesterol or lipid profile, or to blindly use statin?
We can blindly use, but there is no lower level of LDL in. They are saying the lower the LDL level, the better the cardiovascular benefit. But the lower limit is not defined yet.
Yes.
Yes.
But are seeing that in different guidelines.
Blindly, till the patient is adjusting the atorvastatin.
Yes. And what
symptoms are not there with atorvastatin use?
Yes. And what we are seeing from about decades, but guidelines saying the lower the better. Initially it was 100, then 70. It is now below 70.
Yes.
For that, if it is not, if the LDL cholesterol level is not achieved by statin alone, they are advocating use ezetimibe or to other newer drugs. So the lower the better. So no level is low till now.
Yes. And we are getting people with low LDL, low triglyceride level. They are having heart attacks. So the only cholesterol is not the reason for heart attack.
Yes, cholesterol is not the determining factor. Other factors may be there.
Yes.
This is one thing. And another thing, it is seen that with using high intensity statin, we're often seeing patients with LDL cholesterol about 30 or 40, but there is no symptom.
No symptoms.
Initially, after about 10 or 12 years back, there was a concern, particularly from neurologists, that low LDL cholesterol might cause cerebrovascular events like cerebrovascular hemorrhage. Particularly for there is a risk for low cholesterol, low LDL cholesterol may develop ICH. So now I think it is not justifiable now, as we are seeing very, very low level of cholesterol, even 40 or even 30 level of 30 milligram per DL of LDL. We are seeing patients with we are using high intensity statin.
Yes.
Dr. Das, in case of type 2 diabetes patients, we are all using statin for primary or secondary prevention of SUSDs. But what is your experience with type 1 diabetes patient? They are very young and often they are below 40. Are you using statin for type 1 diabetes patients?
Yeah. Both in type 1 and type 2. But most of the patients are the type 2. Those patients with the type 1 diabetes more than 20 years, there is a definite of some cardiovascular complication. And those with the type 2 diabetes after the 10 years is the high risk factor. So both in type 1 and type 2 diabetes, we can use the statin, but in my clinical practice, the type 1 diabetes are very few. Only the 7 type 1 diabetes patients are dealing now in Alipurduar district hospitals still now. Among them, only the 4 are getting the rovastatins along with the aspirin, ecospirin AB, fixed dose combination therapy. They are now the better due to the close monitoring. They about there, the age is now the 31 and 22, 31, 32 still now. Only very few patients having with us. So from the little experience, that both in type 1 and type 2 diabetes have a definite role, because beyond the lipid lowering agent, the statin, have the other the various action, like therapy action already discussed in this galaxy. If the endothelial function improvement, platelet stabilization, etc. Even anti-inflammatory effect, those with the CRP protein the high, particularly more than the 2.5 or 2, particularly in type 1 diabetes, there is a definite role of the statin. In such cases, either atovastatin or rosuvastatin is the better to start.
In case of type 1 diabetes, are you using aspirin for prevention of secondary or primary atherosclerotic cardiovascular disease? Are you using aspirin in young diabetes patients along with statin?
For the few cases only, 2 to 3, because the family, there is a strong family history of cardiovascular event, atherosclerotic cardiovascular disease. So we can use particularly the 2 or 3 patients.
So only in patients with who are having a strong family history of cardiovascular disease, particularly in case of young or premature cardiovascular disease, you are using aspirin or clopidogrel. What is preferable, aspirin or clopidogrel? Which antiplatelet drug you are using for type 1 diabetes?
Still now the aspirin, because the value is one of the important factor. For our patients, we can use the aspirin, but the clopidogrel definitely the better.
Dr. Maiti, can you hear me?
Yeah.
So, sir, can you emphasize on what are the different pleiotropic effect or non-lipid lowering effect of statin, for which we can prescribe statin?
Pleiotropic, it reduces all the statins, reduces all the major adverse cardiac events, and as well as they are beneficial in case of fatty liver, NAS. In all these aspects, statins is preferable. And regarding their use, particularly in obese patients, it helps in reducing body weight by so they can be used in basic sort of inflammatory. So they are helpful in that, because atherosclerosis, hypertension, diabetes all belongs.
Voice is breaking.
Hello, am I audible?
Yeah, audible.
Can't hear Dr. Maiti.
Yeah. So I answered this because statins with their pleiotropic benefit, because these are diabetes mellitus, hypertension, and atherosclerotic diseases, heart diseases, or atherosclerosis itself are belong to inflammatory disorders. So statin, in all respect, they are useful in these conditions, as well as in non-alcoholic fatty steatohepatitis, fatty liver disease. These are the some other conditions where statins can be used, and because of their pleiotropic benefits.
So beyond lipid control, it is also an anti-inflammatory drug, and we all know that for development of atherosclerotic cardiovascular disease or for atherosclerotic plaque, the inflammation is a very important risk factor, particularly for intima of the vessel. So, Dr. Mohapatra, Dr. Mohapatra, can you hear me? So, are you seeing that there is any objective evidence of there is plaque regression, particularly for coronary arteries? Suppose you are doing an angio and seeing this patient is having 40 to 60% disease, and you are prescribing statin and other antiplatelet drugs, and if you follow up the patient for after 1 or 2 years, is there any chance that plaque is regressed? The disease is regressed from 40% to 20% or from 60% to 40%.
There should be, but yeah, we usually don't do angiogram unless the patient is symptomatic.
Now, suppose a patient of symptomatic stable ischemic heart disease. For SIHD patient, for patient benefit and for reduction of risk, you have to do an angio, and you are seeing that patient having intermediate disease. So below 70% disease, that the plaque is there. That patient you don't put stamps.
With statins, there is definite evidence of plaque regression and decreased plaque burden. But there is chance of AMIs also in that case.
In case of suppose you get an intermediate disease, in that patient you have to do an GDMT. Not you can't put a stent in that patient. Putting on statin and aspirin and or ticagrelor for 1 or 2 months, 1 or 2 years. After that, if there is any chance that you are doing and follow up angio, whether there is any chance of plaque regression or not.
Actually, patients are
follow up angio.
Follow up angio patients don't usually prefer second or angiogram. That's why
unless become symptomatic on like development of acute coronary syndrome.
Yes.
Okay. This is a problem.
Actually, for study purpose, follow up angiogram is necessary. But here in a private setup, you cannot go for a follow up angiogram.
Follow up angiogram. Okay. Dr. Das, we are using statin for long period, about 2 decades particularly. So is there any concern for neurologists for development of patients who are using long duration statin in development of multi-infarct dementia, or patient of development of, or there is any chance of development of multiple small infarct, particularly for lacunar infarcts?
There is the chance, but it's reversible. There is some cognitive dysfunctions also. But in my experience, initially when we use the moderate intensity statin, a few cases showing the confusion, but in my experience is reversible and the transient cases, and some patients also showing cognitive behavior abnormality due to the age effect. But in the younger patients, we can see too much. Only the few patients showing this abnormality. In my experience, another side effect we can get is the myopathy, even in the young patients. But very few, only the 3 or 4 get this year. But the history is that most of the patients having either the alcoholics or the other regular disease, etc. But what the recent experience is that one patient on the statin with diabetes, and when he is suffering from some fungal infection, he got the itaconazole for a long time, and that patient is having with some myopathy. So initially we confused due to some peripheral vascular disease or other thing, but after stopping the statin and stopping the itaconazole, patients regress rapidly and show the good improvement. So azoles group, particularly the itaconazole or fluconazole, can aggravate the myopathy, etc. Regarding the cognitive behavior, we have the little experience. Probably most of the cases is the reversible and transient. Dr. Ghosh.
Yes. So statin should be used, and I think above 40 years, patients who are on who are having diabetes, or patients of primary prevention, or patient of risk of atherosclerotic cardiovascular disease, if there is any chance above 7.5%, so we are using statin, and for duration of statin is not definite. maybe lifelong.
Yeah,
So can we
definitely.
supplement statin? What is your thing? Can you supplement statin with different food items as well as supplement iodine for salt?
Actually, we don't supplement if there is few cases of the myopathy, but there is the strong evidence where the CK creatine kinase levels is more than the 10 times. We can stop. But still now, in my experience, any patient, in any patients, we cannot stop still now because the such level of the myopathy can not get in my experience. It's only the theoretical. If the CK level is the more than 10 times, we can definitely stop the statin. Otherwise, it can continue.
Actually, what we are saying that myalgia is more subjective myalgia, but the objective myopathy or raise of CPK enzyme is less probably.
Less probably.
So subjective myalgia, which can be easily controlled with NSAID or for paracetamol or for after stopping 5 or 7 days. If you can restart statin, I think the myalgia often gone.
Past 2 months only, these myalgia incidents are more in statin dose. After that, they used to take without myalgia actually.
Yes. Now, Dr. Mohapatro, if you get a patient with atherosclerotic cardiovascular disease like acute coronary syndrome and cannot use statin because of high level of CPK, particularly in patients of myalgia or particularly development of subjective, not objective, objective myopathy, what can you do? Can you stop statin or replace with other drugs?
Such incidents are not yet
So much. Yes.
And we can use PCSK9 in that case actually.
Incidence is less, definitely. There is less incidence of myopathy so that we can stop the drug. So this is a very interesting discussion today, and I am very much pleased to have our eminent panelists, Dr. Mohapatro, Dr. Rana, Dr. Maiti, and Dr. Das. So is there any question from the audience? Mr. Agarwal, is there any question from the audience?
Dr. Ghosh.
Yes.
Sir, one question, sir. For PCI patients, sir, what will be the PCI, sir?
PCI?
Yes, sir.
Yes.
So what will be the loading dose for either rosuvastatin or atorvastatin, and how long patient will continue the same for PCI patients, sir?
Okay, I think Dr. Mohapatro has nicely elaborated it. Dr. Mohapatro, can you please enlighten again?
That high intensity statin, that is in case of rosuvastatin, we are giving 40, and in atorvastatin case, we are giving 80. For that dose is continued for at least 3 months.
Okay, sir.
So Dr. Mohapatro has said in case of PCI for primary or delayed primary or for any other case of stable heart disease, stable ischemic heart disease, they are doing PCI. And for this high intensity statin is preferable, 80 milligram atorvastatin or 40 milligram rosuvastatin, and to continue at least for 3 months and if possible for one year. Then you have to switch to moderate intensity statin. Is there any question from the audiences?
No, sir. Any patient below 20 years and above 12 years. So,
yes.
Sir, there is any restriction for using statin, sir, or there is any specific dose? More than 12 years of age, sir, having lipid problems, sir.
Yes, so particularly for hereditary dyslipidemia, you are saying?
Yes, sir. Yes, sir.
Yes, Dr. Maiti, can you enlighten on this topic of hereditary dyslipidemia, a case of child or adolescent above 12 to 20 and having high LDL level? Can you use that?
We can use statin either atorvastatin or rosuvastatin 5 milligram, or we can start with atorvastatin 10 milligram. But I have not much experience in this respect.
Actually, there is a problem in pediatric age group that development of brain, particularly brain development, and if we lower the cholesterol, particularly LDL, in this age group, there is chance of any deformity or particularly for developmental problem. But what we are seeing that in case of familial dyslipidemia, in different types of familial dyslipidemia with high LDL or high triglyceride level, the decrement of LDL, particularly after 18 years, it is justifiable. Below 18 years, or whether there is still there is development of brain, you have to be cautious when using statin.
Yes.
Yes, sir.
Yes.
Thank you, sir. Thank you very much, sir. Thank you, sir.
Any other question from the audiences?
Arup,
No, sir. There is no question in chat box, sir.
There is no question in chat box. So if there is no question, there is a fine discussion today evening with Dr. Mohapatro, Dr. Maiti, Dr. Rana, and Dr. Das, as well as from the Alkim team. Can you conclude?
Yes,
Can you
yes, sir.
conclude the session?
You can.
Arup,
Yes.
sir, before sir concludes, sir, I'm just sharing one information, sir.
Yes.
This, sir, entire discussion will be available through, sir, YouTube from tomorrow onward. Those who are not participate or attended for this program, unable to see this program, sir, they will definitely see this program from tomorrow onward through YouTube, sir. So it will be available YouTube from tomorrow, sir. Entire discussion, sir.
Okay. Thank you, Welcome Cardiology, everyone, for giving us a platform for discussion of this topic. And I also thanks our eminent panelists, Dr. Das, Dr. Mohapatro, Dr. Maiti, Dr. Rana, everyone. So with everyone's permission, we can conclude this
Very much.
session. Thank you, everyone. Good night.
Thank you.
Thank you, sir. And we take this opportunity
Thank you. Good
to
night
thank,
to everybody.
Okay.
to thank Dr. Somojit Ghosh as a moderating the panel discussion, and all the panelists for sharing their views in Galaxy, views on rosuvastatin and clinical practice. I would like to thank all who have joined us for panel discussion, and I am sure we will appreciate this Galaxy on rosuvastatin presented today. Thank you, sir. Thank you very much. And we at Alkem Laboratories, we continue this serve to the doctor, to you, sir. Thank you.
Okay. Thank you, everyone. Good night.
Thank you,
very
sir.
much.
Thank you very much, sir.
Good health,
Thank you.
particularly in this pandemic situation.
Yes, sir. Yes, sir. It was nice discussion, sir. Thank you very much, sir.
Thank you so much, everybody.
Thank you, sir. Thank you, sir. Good night, sir.
Okay, good night.
Good night.